So for everyone that doesn't know me, then I'm Rebecca Redwood. I'm a CAMS consultant working in the North. And I've got great pleasure this morning in introducing Dr. Mary Barrett. So Mary's a consultant psychiatrist for adults with intellectual disabilities working in the East Midlands. She's also the training programme director for higher trainees. And chair of the ID Speciality Advisory Committee at the college. So in that last role, she's overseen the development and implementation of the new Royal College ID training curriculum. So Mary's very kindly talking to us on a subject that's of great interest to and relevance to trainees and trainers alike, which is the new curriculum. So what we're hoping there's going to be lots of time and lots of kind of space for questions at the end. So thank you very much, Mary, and over to you.
Lovely, and thank you very much to Kahindi for inviting me, and to you, Rebecca, for chairing. Obviously, I'm presenting. I've only got access to one screen, so I can only see one person at a time, and I won't see hands up. So, Rebecca, if you can keep an eye out for questions and whatever. I'm happy to stop as I go along. I'm going to want lots of participation anyway, because I think that's more useful, and there will be time at the end to discuss and ask more questions. We have been hoping that a very kind trainee who's on the new portfolio will be willing to show us their portfolio just and demonstrate how they set up a PDP item. So if anybody is feeling brave and willing to do that, that's really helpful. But if not, I can quite understand you might not want everybody on the call viewing your portfolio, so we'll see how it goes. Rebecca, I'm just getting notifications saying there's people waiting in the lobby, so I'll leave that one with you. There's nothing I can do about that. So I'm just trying to move my slides on, which don't seem to want to move. There we go. Lovely. So I'm starting with what's normally the last slide, the resources, because the new curricula are here. Many trainees and trainers will now be using them. And so I think rather than me saying to you, this is the curriculum, this is a key capability, this is an HLO, I'm hoping you know that. And what I want to do is spend some time looking with you at how we implement the curriculum, some of the resources to help you, which you may and may not have looked at, and many people haven't. So don't feel bad if you haven't. So what I'd like everybody to do now is to Google, or whatever browser you use, RC Psych Curriculum Hub, and open up the hub, where you'll see all these different documents that I've listed here, because what we're going to do with this session is actually have a curriculum quiz, and the answers for the quiz will be on the hub. And the purpose for doing it this way is that hopefully you'll get familiar with the resources. You might even be tempted to download a few and then use them and reference them, and then you'll be fully armed before you get to the first round of ARCPs. So yeah, RC Psych Curriculum Hub into a browser will bring up the curriculum page. You'll see some of the pictures on my screen. They'll be on there, so you know you're in the right place. And then you can click on the different things. And I think it's just useful to make sure everybody's using this as a resource, because this is the main resource we have now. You'll see all the documents that are on there, and I'm going to refer to most of those as I go through the presentation. I've popped the email for queries on there. Kahindi, I know we talked about the fact we were expecting people to use the drop-in sessions to get queries answered. There really hasn't been much demand for those, so for the moment those are suspended. So if people go to the website hoping to book onto a drop-in, that's not going to happen. You need to be looking in other ways to get that information. It could be emailing, it could be contacting somebody who knows, contact your TPD, contact HEE, you know, just to get that guidance. If I were you though, I'd speak to peers. So I'd speak to trainees and trainers, because they often know more now than some others. So my first question in the quiz is, what is the Silver Guide? So where you can find it has already been answered, which is on the RC Psych Curriculum Hub. But Rebecca, I'm hoping you can help sort of correct answers for this, but is anybody feeling brave and wants to put in the chat or speak out and say what they think the Silver Guide actually is? Because it's an important document and people should be accessing it.
Okay, so we've got a few answers now. So someone's saying it's the Holy Grail.
They're very right. Yes, that's good. What else?
And a very detailed answer. It sets out the curriculum framework and key features, explains education and formative and summative assessment methodologies deployed under the framework. I feel they may have cut and pasted this from
but that's great, because that means they've got it. They found it. So brilliant. Yes. Yeah. So well done. So it's the new overarching guide to training in psychiatry, and I've got a slide in a minute that tells you some of the key features, but I think whoever put that answer in has already listed some of them. Anybody know why it's called the Silver Guide? The answer to that won't be on the hub.
Does it follow on from the Gold Guide?
Yes, yeah. It was a discussion we had, one meeting at the college, where somebody said, what are we going to call this new guide? And John Russell said, well, we've got the Gold Guide, the CopMed Gold Guide, that all the educators use when they're thinking about ARCPs and tricky training questions. So we said, oh, let's have the Silver Guide. So that's how it got its name.
So quite a few people know that on the chat. So they've referred to the Gold Guide.
Yeah,
someone's written cutbacks as to why it might have become the Silver Guide.
Well, I did say, could we therefore have either bronze curricula or platinum curricula, but they wouldn't go that far. They got a bit worried, I think, that people think we were taking the mickey. So we stopped at Silver Guide. But yeah, so this lists, so basically, whether you're a trainer, a trainee, a TPD, it's got everything you need, as well, many things that you need with regards to psychiatry training, and it is really useful. And it's the sort of thing, I think when I was a trainee, I would have thought, oh, I'll look at that at some point. But actually, there's stuff in there that you'll find really useful and will help you plan your training and think through what you need. And for trainers, it's you know, sort of, you can keep referring to it, pick the bits out you need. It's easily downloadable as a PDF, and then you can search it for whichever bit you need. So do have a look at it. So I'm hoping everybody should be able to answer this next question. What is a PSPDP? Any answers, Rebecca?
Anything to do with personalized and flexible PDPs?
Excellent, yes.
A person-specific PDP. You've got a few answers coming through.
Now it's a placement-specific PDP.
Yeah, that's come through as well. So placement-specific PDP.
Yeah. So it is person-specific. That's why it's a personal development plan, but it's placement-specific. So for a typical CT, how many PSPDPs do you need per training year?
No specific number?
Oh, there is. The clue is in the title, placement specific.
So 2 is coming through as a yeah.
So the answer is it depends on the number of placements. So it's usually 2 for a CT. So for each placement a trainee does, they need to be setting up and completing a PSPDP. So that's on your portfolio, and that's the way you decide which of the key capabilities you're going to focus on. You decide how you're going to achieve them, you evidence them, trainer and trainee both put information in, and then hopefully with a click of the button at the end of the placement, most of it pulls through to form a good part of the level 1. So, you know, old money clinical supervisor report. So it's the key way of pulling your information together now. Previously, I think PDPs tended to be set up at the start of a training year or something, and then at the end, people go back and think, oh gosh, yes, I've done all these, I'll tick them off. the point is we've tried to bring the PDP as central to how the training runs. It's got the curriculum embedded. And the idea is then it really makes you think about how you're going to meet your capabilities and sort of work your way through the placement. And it does give you that bit more structure to your supervision. It does take some time, but once it's up and running, it works quite well and it saves time at the end. And where can you find example PDPs? Because that's been the big panic. What do I put in it? Well, we've created some examples. Has anybody found them?
RC Psych website.
Yep. So the curriculum hub, which hopefully for people who weren't here for the first few minutes, I've suggested you Google RC Psych curriculum hub and then go on to that and be looking at this while I'm doing the presentation, because you'll find all these things. So yep, there's one of the drop down menus. You can find all the example PDPs. So again, it's on the curriculum hub. And if you're a core trainee, these are all the sample PDPs you've got access to, and more will be added as time goes on. So as you can see, there's ones for general placements, there's ones for specific placements, there's one for subspecialty placements. So it just gives you an idea. And I mean, this is not a Bible and you're not supposed to copy this. The point is it gives you examples and shows you people working in those sorts of subspecialties have come up with them. So it gives you an idea of the sort of things that you might be expected to cover. So Rebecca, I don't know, I'm not going to focus any more particularly on PDPs just at this minute. So I don't know if anybody had any burning questions or we can cover them at the end.
So I think what I'll suggest is if people have got burning questions, do you want to just put them in the chat and then we'll sort of collate them at the end and come back to them?
Yeah, that's fine. Otherwise it can get a bit disruptive. So yeah, and so for each higher training scheme, there's some sample PDPs on there. Some have got more than others, depending on how many the SACs have been able to produce, but this will be added to over time, hopefully. Oh, now this is a good one, and it might seem a little pedantic, but it's just to make you have a look at what's required. How many workplace-based assessments are recommended per CT training year? And I'll give you a clue, it's in the Silver Guide. But does anybody actually know? And the key wording here is recommended. There's nothing mandated. We had a lot of issues when we developed the curriculum with what could we mandate and what couldn't we mandate. For example, we can't mandate a 6-month developmental psychiatry post because not all areas of the country can deliver it. So we have to say recommended, which, you know, people are not happy with, but it's the way it goes. But yeah, so how many workplace-based assessments are recommended per CT training year? Rebecca, has that stumped people or are people having a go?
People are having a go.
Excellent.
Suggestions, 12 or 14.
Oh, okay, we're getting closer. So it's a slightly sneaky question because it depends on your training year. So one point is it changes. It doesn't necessarily mean that what you do in CT1 will be the same as what you do in CT3. Any more numbers come up before I reveal the exciting answer?
Okay, we've got as many as you feel you need to achieve your PDP.
Well, that's a good answer, actually, yeah.
And 10.
Okay, so I don't know if the as many as you need was a trainer or a trainee. I think it's as many as you and your supervisor feel you need. So yes, and there is a way now of using the workplace-based assessments to gather more information per assessment, which can cut down the number you need to do. But if you look at the Silver Guide, 16 in CT1, 17 in CT2 and 18 in CT3. The logic for that, I don't know. And that includes 2 rounds of mini-PAT each year. And so if you look at page 88 of the Silver Guide, there's a lovely table that sets that all out. So the point is it's all there. And so for each of the higher training curricula, there's a similar table with recommended numbers and what you need to do, you know, what it recommends. So if you look at that at the start of your training year, that'll give you an idea what you need to be working towards. So I think that can be quite helpful. So shall I carry on, Rebecca?
Yes, please do. Yeah.
Okay. So what is a psychiatric supervisor? Because this is the term that's used in the Silver Guide now.
There's some suggestions that that's your clinical supervisor.
So basically, it's what was, because I think people got themselves tied in knots. So people would colloquially use clinical supervisor to be the person that was responsible for the trainee's placement, that did the level 1 report, but actually that was supposed to be a named clinical supervisor, because anybody working with a trainee and offering supervision is a clinical supervisor. So the terminology has changed to psychiatric supervisor. So that's the equivalent, that's what we still all use the term clinical supervisor, but it's just to be aware that the actual proper term is psychiatric supervisor, so that's what will be used in the documentation. But day to day on the ground, we're still using clinical supervisor, named clinical supervisor. So bearing in mind that that's what their job is, what do people think are the key roles for the psychiatric supervisor now? Because there's an additional one popped in with the change in curriculum and the change in portfolio. Because trainees need to know what their psychiatric supervisors should be offering them, and equally psychiatric supervisors need to know what they should be doing, because if they're not getting it right at the start of the placement now with the new portfolio and curriculum, it is going to cause issues, which is why I've put this in. So do we have any suggestions?
So we've got supervision, development of your PSPDP, and reflective one-to-one supervision. Another one is overseeing clinical skills, competence, workplace-based assessment.
Brilliant. Yeah. So the key additional thing is that the supervisor is one of their key roles is to help the trainee set up the PSPDP, help them choose the key capabilities and think how they're going to evidence them and what they're going to do. And then the psychiatric supervisor needs to be reviewing that regularly with the trainee in the 1 hour supervision to make sure things are on track. It will help them. It's more work at the start, that's very clear, but once it's set up and running, it will make it much easier for completing the level 1 report for the ARCP when you get to that point, because everything should be in there and linked already, and you've not got that horrible scrabble round for evidence that you sometimes end up doing when you're trying to evidence things at the end of the placement. So hopefully all our psychiatric supervisors on the call have supported their trainees who've moved to the new curriculum and new portfolio to get their PSPDP up and running, but they haven't. That really is a priority, and it's about keeping track of it as well in supervision. So one of the things that the GMC really challenged us on is how can we demonstrate progress for trainees over the years? Because the way the new curriculum is set up, as you'll know, is you've got your HLOs, your sort of overarching learning outcomes, then you've got your key capabilities, which are a set of statements about what a trainee needs to do. But they don't give, they're very broad deliberately, because any wording that we change in there has to go back through the GMC. But how can we show that a trainee is progressing? You know, how can we show that they're really moving forward, and what we'd expect of a CT1 in the clinical domain is different to what we'd need in a CT2? So I'm going to tell, had anybody noticed this? That we've changed from capabilities, sorry, changed to capabilities from competencies. Does anybody know why we've gone for that, what the logic of it is? And people may not, but it's a minor change in the wording, but it's actually quite significant. Are we getting any guesses, Rebecca, or is it a bit of a a tricky one.
Okay. The competency was binary, so that was a sort of yes or no.
Yeah, that's really good. That's spot on. So competency was you weren't competent or you were. So capability is seen as something you gradually develop, and the support you need is less and less over time. So the idea is you can show developmental progress by showing somebody gradually developing capabilities. So that's why we've got key capabilities and not key competencies. Has anybody noticed how the wording of the workplace-based assessment ratings has changed? You know, you've got those sort of, is it the 7 dots? So you've got or is it 6 dots where you've also got 3 dots coming up, and then you've got the dot in the middle, and then you've got the 2 dots when somebody's above expected. Has anybody noticed the changing in wording there? What it says? Because again, this is another significant change and something the college really wanted people to notice and think through. Can anybody remember the wording from the old ones? Because the wording from the old ones tended to make supervisors be worried about using the dots on the left-hand side. How are we doing, Rebecca? Anything?
Not yet. This one.
Okay, no, that's fine. So basically, so we've adjusted the workplace-based ratings, and I'll show you an example in a minute, because to be fair, not everybody might have seen the new one, but before we used to have below expected standard, and then they've reached the expected standard. Now what we've done is we've changed the wording to working towards the expected standard, and the college expects that trainees will be in those dots below the expected standard for most of the training year. Their argument is if trainees for workplace-based assessments at the start of the training year, they're being shown as at expected standard or above, then why on earth are they in that training year? You know, we should be showing progress. So the idea is that workplace-based assessments use those working towards buttons much more than we have done previously. And what's clear now is that the workplace-based assessments are being rated against whatever the end of whatever training year the trainee's in. Because with the old workplace-based assessments, some of them you were rating them against ST4 to ST5. So how on earth could you ever show progress? Because if you're ST4, you know, you're not going to be end of ST5 partway through your ST4 year. That just doesn't make sense. So with each workplace-based assessment, you're rating the trainee against whatever training year they're in, the end of that training year standard, and the expectation is that they will work, you know, they'll be working towards it, and they'll be getting the meeting or potentially above only towards the end of that training year. Rebecca, does that make sense?
Yeah, we've got a question from Matthew.
Yeah.
So I don't know if that's on this.
Yeah, it was a comment really on that, because I hope that that's something that does get embedded, because it has been a persistent difficulty that you see trainees who you know, all of their assessments are above, you know, everybody's assessment is above expected standard, and then you come to it and you think, well, how do I give this person any kind of advice or constructive feedback if they've always been rated above expectations, and then I'm saying something which might be that they might not be expecting, and so I hope it does get embedded that you know that we have a kind of slight deflation of gradings, so that you can kind of give people more constructive feedback.
Yeah, no, I'd agree with you totally. That's what we're hoping. I mean, clearly we can't you know, ideally each individual supervisor would be sort of tested to make sure that, and calibrated to make sure that they are within a similar range as their peers, but that's not going to happen. But if trusts, you know, if DMEs and HE areas can really embed this message, I think that will be really helpful. Because the argument actually is, you know, sort of if trainees are above standard all the time, surely their CCT dates should be brought forward. And that you know, and that brings a whole new raft of challenges, and we occasionally do it, but not often. But yes, I mean, I've had supervisors say things like to me, well, I can't give them a bad rating because they'll cry. And you're like, well, have a box of tissues. And, you know, sort of don't give them a bad rating, but give them a realistic rating, and then work with them to bring, you know, sort of to bring things up. But yeah, it's very difficult when you're the outlier. I would agree with you, but hopefully this will help. The other thing that's happened with workplace-based assessments is you now have to write something in the free text boxes. Now, obviously, we can't make people write reams and reams, and actually we don't want reams and reams. But I think what's recognised is the workplace-based assessment process we use at the moment isn't the best, and it will be going for review in the next few years. That's the next work stream to go ahead, but the GMC has to be involved in all that, so we couldn't do it at the same time as the curriculum. But as a start, we want people to write useful comments in the free text boxes, because actually they're often of more value than the ratings. So that's been a slight change. The other thing is the end of year standards guidance. Has anybody found that on the curriculum hub? Can I just check, is that something people were aware of? The end of year standards guidance? No. Oh, yeah, this is good actually. Suddenly the messages have started popping up on my screen now. That's going to cause me problems if I can't move on, but hopefully I can. So yes, so people are, and this is something actually that's really helpful. So I'll show you hopefully something that, if it will let me move on. Right, let's try. Yeah. So the end of year standards guidance gives you examples of behaviours a trainee could be expected to demonstrate at the end of each training year. Now, it's not a prescriptive guide, but this is one way the GMC liked this approach, and it was really, really hard to write. But what we did was we came up with a set of consensus statements that would show you what a trainee would be like at the end of CT1 for a certain capability, as opposed to CT3. So I've got an example to show you. So these are the couple of things. So here's the workplace-based assessment. So for those of you who haven't seen it, this is a snapshot of part of the document. So you can now potentially relate all the HLOs on nearly all the workplace-based assessments. And that means that you can get more out of each workplace-based assessment, because it encourages supervisors to think about all the different domains. So that goes back to the comment somebody put in about you need to do enough to meet your capabilities. Well, this will help you with that. It may be that a workplace-based assessment can achieve many domains in one go. I've already explained that you rate against the standard expected at the end of the current training year, but you can choose unable to comment if you can't, if it's not relevant to the particular workplace-based assessment. And just to reiterate again, most trainees will be working towards the expected standard, so they'll be in those 3 grey dots to the left until they approach the end of the training year, and that's something I think we need to really try and embed, as we've discussed. And here's just a snapshot of the end of year standards guidance. So you can see the AHLO and the themes, so team working and leadership, and that gives you a snapshot of what we'd expect at the end of CT1, CT2, CT3 for each of those. So there's a separate end of year standards guidance document for, for the different higher training schemes as well. So there's one for core and then there's some for higher. And believe me, that was actually the most challenging thing to write, because articulating how you know what a CT2 looks like in a succinct few sentences is so difficult. But I think actually it's worth looking at, and it is useful. So I think this is the last question. Who who's aware, are there any resources to help prepare for ARCP? Because there's one other significant document, which if you're looking at the hub, which I hope you all are now, you might be able to find it. Anybody want to pop in the chat what there is in there that you found? And you might say to me, well, why are you telling us about this now? But the point is, if you look at it now, it helps you plan your training and your training year.
So there's a document, ARCP decision aids.
Yep, that's the one. So everything we've got, and there's 2 ARCP decision aids, one for core training, one for higher training. And this is the first page of the core training one. And it's like a summary checklist of what we'd be expecting for ARCPs. And the idea is, what we found was that actually ARCP processes are really non-standardised, and what might be required for core training or any particular higher training scheme in one area of the country was very different to another. So this is a way of trying to standardise that a bit. And so it's worth looking at the start of the training year, because it tells you what sort of things you need. And also obviously it's designed primarily for ARCP panels and TPDs, but I think it's got much wider use and people should be aware of it. And then just a couple of little things that are coming soon but are not available yet. RID SAC is a bit ahead of the game, and we've created nearly all of what we've called our library of activities. So what that is a series of activities that trainees might undertake to achieve or go towards a particular HLO. So our HLO 7, which is about working within legislative frameworks. So this is one of the key capabilities about working within legislative frameworks for safeguarding. And then we've come up with, I think this was the one I wrote. So there were 4 statements about things trainees might do as an activity, you know, to work towards that HLO. So they should be coming. All the SACs will need to produce them, but some have had a bit of a derailment for whatever reason. But they will be coming to the website soon. So hopefully that'll be another useful resource. And I'm hoping, what I've asked is if the portfolio team can start to pull off activities off people's portfolios, so we can start to bank those and make that list up and give some pointers. I mean, obviously experienced trainees and trainers won't need these sort of things, but for new trainees, new trainers, or, you know, like me, I normally have an ST trainee, but I had a CT trainee last year, and I was like, well, actually, what should they be doing? Because it wasn't something I dealt with personally for a while. So this, again, would have been useful for me. So this is something to be aware of. And dual training PDPs are coming, because that's been a big thing. How are we going to work this? You know, how's your PSPDP going to look if you've got 2 curricula, blah, blah, blah. So CAMS ID have been the first to pull one together. This is just for showing here. This isn't for sharing, because it hasn't actually gone through its full college approval yet. But as the sort of the education committees at the college are happy with it. What we've got here is, you can see, and apologies, I know the text is a bit small, but I just want you to get the principles. So we've got the 2 curricula aligned. So so you've got the first column. The second column is the learning disability. We're still learning disability because we can't change until the government's approved it. So we've got the learning disability key capabilities. We've got the aligned CAMS curriculum capabilities in the next line. So you can see there's lots of common statements. We then have got a column for which placements we think the key capability could be achieved in or refined in. So it could be in either, it could be in both. So, you know, you might be doing a learning disability placement and actually you could get some of your CAMS stuff done because it applies there too. Yeah. And then we've got some that trainees need to do in both, and then they need to refine that in the final year because it's specific to the CAMS ID placement. And for those ones where there's a final year need for it, we've provided some sample activities and thought about some of the evidence that might support that. So we're hoping that those will be produced for all the dual training programmes, though we're very mindful that actually, I hadn't realised some dual training programmes like forensic psychotherapy, there's no overlapping year. The trainees sort of flip from one placement to another, so that'll be more of a challenge. But interestingly, I've been writing an article about training for neurodevelopmental disorders for BJ Psych Advances, and looking at the curricula, actually there's more common statements than I think people realised. So there may be a way for some commonality to be reached, even if the training programmes don't have that combined year. So that's coming soon, once it's gone through all its approvals, and I think that will be really helpful. That's what I'm hoping. Now, navigating the new portfolio, Hindi, I'll come to you in a minute because I'm not sure if we had anybody able to support us with that. We were hoping we'd have a trainee who was able to show how they set up an activity on their portfolio, because often that's what people want to know. But what I would say is, if you're looking at the hub, there's an e-learning package on how to do a PSPDP. It should by now hopefully be linked to CPD points, but actually, if you're really struggling with knowing how to do a PSPDP, there's an e-learning package on the website that you can do and will help you. I can't demonstrate it because I can't show you any of my trainees' portfolios because that wouldn't really be acceptable. And actually the trainees are the best people to demonstrate it anyway because they're the ones tending to set it up. But yeah, so that's the end of what I want to say. So I'll probably stop sharing now and then hopefully I can see people. Happy to take questions. And as I say, if we've got a trainee who was willing, then please feel free to pop your hand up and do that. Now I can see a hand up.
Good morning. Thank you for the presentation. Quite informative for some of us who don't actually have CT trainees, but tend to have GP trainees. So our mindset's slightly different.
Yes.
I guess my question is that within this new curriculum, is there a tendency to, or what is going to be the process of training requirements for the psychiatric supervisor? I think that's what you're going to be calling them rather than clinical supervisors going forward. Is there any expected changes? Is there going to be certain requirements to keep? And what would be the requirements to maintain your trainer status? Is that going to still be the same, or is that going to change?
There's no plans from the college to change that. I mean, the college is obviously hoping that people will make use of, for example, the resources on the website. They did quite a bit of training prior to the curriculum coming in, but now they're focused on implementation. And to be honest, the requirements to be a trainer depends on your trust. So I know, for example, because from my national role and for ID, in the West Midlands, I mean, an educational supervisor is slightly different, but trainers had to be working as a full-time consultant or full-time equivalent for 5 years before they'd be approved as an educational supervisor. Whereas next door for us, we were saying after 3 years, and then other places were saying we're really desperate. After a year, people can be an ES. So it depends very much on your HE area and your trust. They're the ones that decide what the training requirements are as a supervisor. And it's often to do with your appraisal processes as well and what your appraisal process requires.
Thank you. I think there was a question in the chat about whether trainees can complete trainings quicker than the 6 years. Does the new curriculum allow this?
it's recommended that it's done if you're full-time in the 6 years. There is the possibility of having your CCT date brought forward. It's quite a complex process. You need to be talking to your CS, well, your ES and your TPD probably from very early on. And you have to demonstrate that you're consistently in those above expected standards for your training year, and you can't just decide very close to the end you want to do that. It's normally at your penultimate ARCP that decision is made. The only time we've achieved it for a trainee in recent years, we had a trainee who'd done CAMS, worked as a CAMS consultant, come back into training to do LD training because they wanted to be a dual consultant and they didn't feel they had sufficient knowledge of LD. And we got their training date brought forward because they'd already met a lot of the competencies in CAMS IDs approved for a 5-year programme. So you can do it, but it's complex. The other thing to say is enjoy your training years and make the most of them, because once you're a consultant, folks, you're there. And challenges are can be considerable. So don't rush through your training just to get through it for the sake of it. Make the most of the opportunities. Rebecca, I'll let you coordinate questions because I can't see what order things came up in.
There's a hand up. So Bala, do you want to go?
Yeah, just on the same thing, Mary. I mean, what's the GMC's take on that in terms of the CCT? Is it something that the college has to work closely with the GMC for somebody to be getting earlier than planned?
Yeah. Yeah, go on.
No, previously it used to be kind of specifically written down that you had to spend 36 months in specified posts of for core training and 36 months for advanced training. So that requirement has been taken off. Is that?
It's a really difficult thing, and I think you'd have to look at the exact wording in the Silver Guide, and I can't remember it off the top of my head. The expectation is that trainees will fulfil the 6 years, and it's only an exceptional circumstance where their CCT will be brought forward. Because it's not just about ticking off the boxes. You know, there's increasing complexity in things, and sometimes you just need to do things a number of times. You know, you can tick off the box and say, I've done my however many on-call shifts, but actually the more on-call shifts you do, something different always comes up. You know, so I think it's a really challenging process to get a CCT date brought forward. So it's not something we undertake lightly unless there's a very good argument for it, because sort of duration of training gives people much more breadth of experience. But yes, at the end of the day, the GMC would have to approve it, but it would have to have, HEE would have to have sort of approved it, the college would have to have approved it, and then the GMC would sign it off. So it goes up the level. So if there's dispute at any point, again, you know, it would come to a standstill.
Okay. So apologies, I didn't come to the hands in order. So Sadia, do you want to?
Yeah.
Do you want to go?
Yeah. Thank you. Hope you can hear me. Thanks, okay. Dr. Barrett. A quick one, really. I mean, I know in this audience we have quite a lot of trainees and also both junior consultants and senior consultants. So what I was just trying to kind of clarify with you is, often for a full-time clinical consultant or even part-time clinical consultant, it's very difficult to have the protected time to supervise or teach the juniors, either it is ST or GP trainee or etc. So what I wondered was whether the GMC and the college have looked into this. Is there like a top-down approach wherein the trust has to either mandatory or, you know, as a recommendation that they have to give this protected time for the trainers, particularly supervisors, the number of trainees they're supervising, and how this time is protected, either in terms of additional PAs or in terms of sessions, or there is a kind of a framework so that the trust has to follow as a mandatory rather than as an option. I know it's a bit tricky question, so sorry, Dr. Barrett. So it will be really helpful. I mean, this is an opportunity. They have made changes to the curriculum. This is the right time to actually pin some of these practical and logistic issues which are very difficult for a full-time clinicians on ground.
No, I'd agree with you, and I think it's something that we all wrestle with. And I mean, you might be interested to know that the different trusts across the HEE region manage this in different ways. Essentially, the college doesn't really have any power to mandate what people should be doing, but the college is clear that each trainee should have a protected hour of supervision per week. And so then it's the trust's responsibility to make sure that the supervisors, the psychiatric supervisor has that recognised in their job plan. Some trusts do it by additional PAs, some trusts do it by funding. There's different ways of doing it, but the college, although the college has developed the curriculum, it's very reliant on HEE areas and trusts to implement it. And so it's a really tricky one. Hindi, I don't know if you wanted to make any comment here, because obviously you've sort of got overall responsibility in your trust for thinking through these issues.
I completely agree. I think we have to, certainly within the trust, do what's possible to ensure that time is protected. And we rely really on trainees and supervisors letting us know if there are big challenges with meeting those requirements and obligations. Very occasionally, I think once or twice, certainly since I've been DME, I've had a report come through about someone not getting supervision as regularly as they ought to do. But we are reliant on it being fed through the system. Having said all that, though, we have plans to feed into the meetings with CDs a bit more proactively, so that we are getting discussions underway about job planning, not just for supervision weekly for trainees, but also job planning needing to capture undergrad activity as well. So hopefully we can move to a direction where we're performing a bit better on some of that than we have done historically.
Yeah. Thanks, Candy. I think if you have the sight of the issue and wherever it is possible to raise it, and if there are consultants who are struggling, probably it's something that needs to be addressed, I guess. Yeah. Thank you, Dr. Barrett. Thanks, Candy.
No, we've got another question, hand up, which is Elias. Do you want to go?
Yes, if you can hear me. Is that all right?
Yeah, that's great.
All right. Yeah, I'm an ST5 dual trainee medical psychotherapy and general adult. There is a query I did have specifically about the curriculum, and it's one which I did raise by email to the curriculum people. I had an email back saying, I think months ago, saying we're going to discuss it with our advisors, and I've still had no response. So I wondered if you could give any insights into this problem. Or just and also I've raised this with other colleagues, and some colleagues see it as a problem, some don't, and so it's a bit of a contentious issue. And it's the inclusion in, I think, all of the curriculums, this key capability of, and the phrasing is, recognise, validate and actively address systemic and structural inequalities, intersectionality and their impact on clinical outcomes for patients and their careers of all ages and on working relationships with colleagues. So I am not in any way doubting good intentions in including this, but some of specifically the phrase intersectionality does bring in extremely polarizing social justice narratives, which actually I think don't sit well with multiple colleagues. I'm aware that the Royal College has adopted many of these causes wholeheartedly, and that's as we've not been required to 100% support them in every stance they take, that's okay. But then to actually codify it within our curriculums is, I think, another step. I'm just wondering whether that was in the discussion of the curriculums, because it does, I think it does feature in all of them, the core, the medical psychotherapy, all of them, it does feature there. I wonder, I'm trying to get a feel for whether that was something which was questioned at all before using that particular wording?
Yeah.
I mean, there are other ways it could have been written, and myself, I find it quite concerning, and would be concerned for other people who also have these concerns and wouldn't feel able to voice them, or don't really understand what the phrase means even. That's actually the majority of the case. But actually, when you look into the history of it, it's not simple in any way, no.
No, I'd agree with you. You might be interested to know, I think we spent a whole meeting debating that particular key capability. There was a lot of discussion and varying viewpoints that led to the wording that was chosen. We had a number of people on the curriculum working group, including patient representatives, carer representatives, people from different branches of the college, people from various special interest groups coming in, and we ended up coming up with wordings that we knew, people may struggle with. It's really difficult to sort of meet everybody's needs. And it doesn't necessarily mean that if there's a lot of feedback, for example, that is unhelpful, then over time these curricula will be reviewed, and any changes to have to go back to the GMC. But if it's proving unhelpful, then those sort of wording may change over time. And I don't know if that really answers it, but I particularly remember the issue around intersectionality, because there were quite a few people in the room who said, we don't even really know what that term means.
Okay, yeah, I mean, that's good to hear that at least it was questioned a bit. I think it's probably something which does need more discussion. And I'm also conscious that it is a discussion which gets shut down very quickly, of accusations of, oh, you're racist, or you're this, or you're that. That's the reason you don't like it. But actually, no, there are other perspectives from which people might be coming at this issue.
Yeah. So what I would say is, obviously you've sent that query in. I would send it back, because I think the problem was we were so pushed for time to get everything through the GMC that the approval from the GMC finally didn't come until literally a couple of weeks before the curriculum had to be implemented. So I think some queries we just hadn't got time to give full voice to. So it might be worth you chasing that, because then it can be brought to the attention. And the other thing is, I mean, we are now moving forwards, and a lot of the curricular committees are going to be repopulated with people. So if there was issues that people felt strongly on and they wanted to take a more active role in this, my advice would be to you to either link up with somebody on one of the committees, or get in there and do some of the work, because it's jobbing clinicians like you and I that are running this. It's not sort of higher plane people. It's people from the East Midlands, from London, from Scotland, doing our best. So it might be something you'd want to think about getting involved in. The medical psychotherapy SAC, actually, they're just having a change of chair, and I know they'll be looking for new members to come on. So did you say you're dual training in that?
Yes.
So have a think.
Okay, thank you very much.
Okay, so I think there's one quick question in the chat, which is, if a trainee is less than full time, is the hour of supervision pro rata?
The answer from my perspective is no. I think trainees should have a protected hour per week, whether they're there 3 days a week or 5 days per week. It may, obviously sometimes we use the whole hour, sometimes we don't, but it's the principle of that protected space. It's like trainees still have, there's various things, as a part-time consultant, I still have to do as much CPD as full-timers do, and people will say, well, that's silly, but actually it's about having that opportunity and that skill set and keeping your skills up to date and whatever. So from my perspective, it should be sort of whether you're full-time, part-time, you get that hour.
Yeah, I mean, I was reflecting, I think as a clinical supervisor for it's never really occurred to me to offer less than an hour a week.
Yes, you could just imagine people
training.
calculating how many minutes.
No.
Did I see another question just flash up?
Do flexible trainees need the same number of workplace-based assessments?
So the answer is yes for your training year, but for example, so say a trainee is 50%, their first ARCP will be after for STs. So for the example, so 50% time in training. So, you know, the first year we'll be assessing halfway through ST4. So we'd be expecting to have had half of the total number required for ST4. And then the other half will be assessed at the next ARCP, which will be in a year's time. So you need to do the required number for the full ST4 year or ST5 year, but they may be more spread out because your training's taking longer. Does that make sense?
I think so.
Yeah.
I just want to say a really big thank you, Mary. That was a really excellent kind of presentation, and I think it's been really, really valuable. I think
Good.
for all of us. Lots and lots of thank yous in the chat, which I'm not sure if you can see.
Oh, I probably can now. Actually, if I switch it on, it just means half my screen disappears. Yeah.
Yeah. So I think if we. I don't know if there's any last comments or thoughts before we draw things to a close.
Just wanted to add that I want to thank you, Mary, for your time this morning. But I wanted to add that we are planning a very brief workshop on the new curriculum at our half-away day, our postgraduate half-away day on the 23rd of this month. So we'll be spending some more time just reflecting once more on this, but it will just enable us to have a bit more space to discuss it.
Yeah.
So thanks once again, Mary. Really appreciate it. I know you've been making the rounds, going to various trusts,
Yes.
discussing the new curriculum, but we're just grateful that you've included us today. Thanks.
No, you're very welcome. It's been a pleasure, and it's nice to see you all.
Okay, thank you everyone for coming.
I'll leave you to it. Bye-bye.
Bye-bye.